Okay, so welcome everyone. My name is Maura Canvan and I am with the Community Health and Wellness Department at Suburban Hospital. Today we are here to discuss hip preservation with Dr. Alex Johnson. Dr. Johnson is an orthopedic surgeon and fellowship trained sports medicine specialist with expertise in joint replacements. He specializes in treating patients with conditions of the knee, shoulder, elbow, and hip. We will have time for questions at the end, so please feel free to send them in the Q&A box as they arise. After the webinar, you will receive a link to the evaluation, and we would greatly appreciate your honest feedback as it helps us in the planning and execution of our community health improvement programs. This webinar will be recorded and sent out in the coming days, so thank you all for being here, and I will now pass it on to Dr. Johnson.
Okay, great. Thank you for that. Alrighty, so I'm going to share my screen here and I hit share like this. And then let me start the slideshow and see what it looks like when I do that. You all see my screen okay there, Mara?
Yep, that looks great.
Okay, good. All right, so today we're going to be talking about a topic, hip impingement and hip preservation. So and we're going to go through kind of, what this means when we talk about hip preservation, who's a good candidate, and we'll cover some other topics as well. We'll touch on some arthritis and things like that also. And then I want to leave lots of time for questions at the end, and I'll be very happy to, take some questions and we can talk about, any other topics as well. All right, so I have no conflicts related to this talk. So first of all, what do we mean by hip preservation? It's kind of an interesting term, and it's an all-encompassing term. It includes many different types of treatments and things, but essentially it's treatments of the hip for conditions that don't require a joint replacement. So it's kind of a catch-all for all the other treatments of hip conditions when we're not putting in a total hip replacement. In it being that, it usually involves conditions other than osteoarthritis of the hip, because the treatment for osteoarthritis is usually a hip replacement. So in order to really understand hip preservation and understand who's a good candidate and what that means, we really do need to understand osteoarthritis in order to understand hip preservation. So what is osteoarthritis of the hip joint? And many of you may already be familiar with arthritis and what that means, but essentially what arthritis is where the cartilage of the joint, the cartilage that allows the joint to move smoothly, both on the femur side and on the socket side, on what we call the acetabular side, that cartilage wears down. And we have some theories and evidence as to why that occurs. Usually it's a combination of genetic factors, and also aging can contribute to arthritis. And when you get arthritis, that cartilage wears down, and then the body starts to respond to that cartilage degradation in various ways. What happens, there's things that we can see in the joint. The joint develops these, what we call osteophytes, or bone spurs around the joint. And it's almost like the body's way of trying to limit motion and freeze up the joint a little bit is with these bone spurs. We also see hardening of the bone around the joint, and we see the space between the two bones start to narrow because that cushion and that cartilage in between is worn down. And so we see narrowing of that joint space, and ultimately you can get to a situation where the bone is really just rubbing on the other bone because there's no more cartilage anymore. So that's what arthritis is. Arthritis, by definition, is lack of articular cartilage, and then the response of the body to that. So how do we diagnose arthritis? Well, arthritis, the main way that we diagnose this, and the easiest way to do it, is really with x-rays or radiographs of the hip. If you look at the patient on the left, you can see that they still have good joint space. If you look at the space around the ball part of the femur, there's a good clear space up above it, and that's where the cartilage is. So we know that there's cartilage there, and this patient on the left has really no arthritis of their hip joint. And I can tell them, yep, that we're not dealing with arthritis of the hip in that patient. Alternatively, the patient on the right has pretty significant severe arthritis of the joint. You can see that the joint space, that clear space, is now gone. And really that bone is essentially just articulating with the other bone. And that's when you may hear the term bone on bone arthritis and things like that. So that's one way, is X-ray, and probably the easiest way. With one picture, we can kind of declare, okay, this is a arthritic problem or some other sort of problem. All right, so another question you might have or may have heard about is okay, if I have arthritis, I may be a candidate for a hip replacement. So what is a hip replacement? A hip replacement is where we actually take out that damaged bone. We take out where the cartilage was and where that bone is grinding on the other bone, and we actually replace it with a titanium stem that goes down the femur, and then a titanium cup that goes into the socket area. And that completely replaces that cartilage and completely replaces that damaged bone that was present. In that little socket that we put in there, we put a plastic spacer in, and that spacer will articulate with a ceramic, usually a ceramic head ball. So you end up with a new gliding surface, ceramic on plastic, and that allows that hip to move smoothly. So that's a hip replacement. And that is the surgical treatment for arthritis. All right. And that's how we handle that. So when we talk about hip preservation, we're talking about situations where we don't have to put in that hip replacement and all the other conditions that would not require us to put in a hip replacement, and other ways to treat the hip joint without doing that. So here's a big question, and one of the most important things that we run into is, who is a candidate for hip preservation? A lot of times it can require an evaluation to make that determination. So those X-rays that we just talked about are one of the ways that I can take a look. If I see an X-ray of a patient's pelvis, I can make a pretty good determination right away based on that X-ray whether they are a potential candidate for hip preservation or not. And it really comes down to the fact of, do they have joint space remaining? Is that clear space still present or not? And it comes down to that question of, do they have significant arthritis in the hip or not? The patient on the left-hand side here, their hips don't look normal. The shape of the hips is a little bit abnormal, but they don't have significant arthritis to their hip, and the joint space is still well preserved. Whereas a patient on the right-hand side, again, this patient has obvious hip arthritis, and the patient on this side, I would say, would not be a good candidate for a hip preservation type procedure. And this is just talking about the surgical approach to these things. So there's many, many non-operative treatments for hip arthritis that you can treat hip arthritis and try and make it better and get good symptomatic relief and things like that without having to do surgery. But when I'm talking about the surgical solution for it, whether a surgical hip preservation solution or a surgical total joint replacement solution, that's kind of what I'm getting at. There is nothing outside of a joint replacement for the patient on the right-hand side that is going to repair that joint or renew that joint or restore the cartilage or anything like that once the joint gets to that level, other than a joint replacement. And I think that's important to understand. And I get these questions a lot about, okay, well, or what about stem cells? Could we inject stem cells into the joint, and would that help? Those types of treatments, they can sometimes make the joint feel better and give you, symptomatic relief for maybe a few months or so, 3 to 6 months, and a situation like that. But it will not remove those bone spurs. It will not create more joint space. It will not grow new cartilage in the joint. We have no evidence that that can happen. So I think that's important to understand. Now we're working on things. We're working on new research to try and find ways to prevent arthritis of the hip and to try and renew the joint without having to replace the joint. But as of right now, when a hip gets to that level, that is the only surgical solution that we have to make it better. And then one more piece on that that I want to touch on is that a lot of times I'll have patients that will come into my clinic and they know that, okay, Dr. Johnson, I know that you do hip preservation. I'm interested in that. And it may be a young patient in their 30s or 40s, and they come in, they've never had x-rays of their hip, and we get an x-ray of the hip and we find that they have bad arthritis of the hip joint. And that's sometimes a just difficult thing for a patient to discover. And it can be a difficult conversation sometimes as well when we're talking about, look, the only surgical solution for you, even in those young patients, is to do a hip replacement. However, once we start talking about it, and we start talking about that option and what the options are and everything, I usually try and leave patients on a very positive note, in that if the surgical solution ends up being a hip replacement, and that's the right option for the pathology that you have in your hip, that is a great option. And it's the best surgery that we have in all of orthopedic surgery. And it's the second best surgery that we have in all of medicine in terms of the way patients feel before they have surgery versus afterwards. So hip replacement patients are probably my happiest patients. It's probably the most reliable surgery that we have. And patients can be very, very active with a hip replacement. I have patients that my personal philosophy is if you can do it with a hip replacement, I'll let you do it. So if you like running and you feel like you can run and you're not having pain running after your hip replacement, I'm fine with you running after your hip replacement. So I don't tell patients that we're gonna, that we limit you after those things. And there's different philosophies, but that's my personal philosophy. And I have patients that run and jump and play sports and things with a hip replacement. So I just want to leave you with that information, and that if you say you're thinking I have hip pain and I may or may not have arthritis of the hip, if you go in and you have a visit and you get evaluated by myself or someone else, and we end up seeing that you got some arthritis of that hip and that ends up being the direction that you need to go, it's a great option. And those patients do really, really well. So, how do we know who is a candidate for hip preservation type procedures? Well, it's really most patients with hip pain that don't have that arthritis of the hip joint. Now, if I have hip pain, all right, how do I know if I have osteoarthritis of the hip joint without getting an x-ray? And that's sometimes a good question, right? Where patients are at home, maybe they haven't been evaluated, maybe you've had hip pain for a while, and you're not sure, okay, am I a candidate for hip preservation? Do I have arthritis or not? Well, there's some simple things that generalizations that can be made that generally you can kind of give you an idea. Arthritis it's the main source of pain in patients that have hip pain over the age of 50. So, if you are a patient that you're in your 20s and 30s, likelihood is that you're not going to have arthritis in your hip joint, that you're going to have some other sort of hip condition that's causing your pain, right? Alternatively, if you're a patient 55, 60, 65, 70 years old, the likelihood is that the source of your pain most likely is going to be arthritis if it's a hip condition. Now, that's a generalization. I have patients in their 60s that come to me and we do hip preservation, and I have patients in their 30s that come to me and we end up doing hip replacements. So, but as a rule, generally that can kind of give you a little bit of guidance. If the pain came on gradually, it may be a sign that maybe it's more of an arthritis type pain versus, okay, I was out running or playing a sport and I immediately had a pain, I felt a pop or something in my hip, then that could be maybe more of a sign that it's another condition. If you have other joints with arthritis, so say you've already had your knees replaced, or you have knee arthritis, well, there's a good likelihood if you're having hip pain that you can have hip arthritis as well. But overall, it's a very simple thing to have you come in, get evaluated, and we can take an x-ray, and we'll be able to tell you what you're dealing with and whether you're a candidate or not for a joint preservation procedure. So kind of moving on now to things other than arthritis of the hip joint, right? What are the other conditions that can cause pain in the joint that are not arthritis? So one of the more common ones that I see is a labral tear of the hip joint. And we'll go into a little bit of what the labrum is and what that means. Another condition is called hip impingement. And hip impingement is where there's an abnormality of the shape of the bone on the femur or the acetabular side, so the ball or the socket side, that causes the bone to pinch against each other. Now, usually a labral tear is a sequela of hip impingement, and that can cause significant pain in the hip joint. Another condition is hip instability, and some patients will have ligamentous laxity and things around the hip joint. They can get some subtle instability of the joint, and that instability can sometimes lead to a labral tear, or it can sometimes lead to pain and problems and things around the hip joint. Hip dysplasia is kind of the extreme of that. So hip dysplasia is where the joint is so unstable, it's so shallow that the hip kind of wants to slide out of the socket, and that can cause problems. Sometimes that can lead to arthritis in the future, but a lot of times hip dysplasia is something that can be treated with non-arthroplasty solutions like hip preservation. Osteonecrosis is a condition where the hip, part of the hip can where the blood supply gets limited, and that part of that bone can die. And in some cases, osteonecrosis can be treated with joint preservation. In some cases, it needs to have a hip replacement. And then one other condition is stress fractures of the hip joint. Usually those are ones where we don't have to do a hip replacement and we can do a hip preservation type procedure. So this is what the labrum of the hip looks like. All right. So the labrum is kind of like the lining of the hip joint. Think of it, I tell patients sometimes it's like an O-ring around the joint. The ball and socket is a very stable joint. The hip joint's very stable. But when you put this labrum around the joint, and when that labrum, it deepens the joint a little bit and it creates a suction seal. So sometimes when we're doing procedures, joint preservation procedures, and we need to kind of sublux the ball out of the socket a little bit, you can actually feel that suction of the joint, and you can, when you pull on the joint and that suction is released, it's almost like a suction cup. And that's what the labrum is doing in a lot of ways, is just maintaining that suction seal around the hip joint. And so that's kind of what the labrum looks like and where the labrum is located right there. And we get a lot of questions on that. So one really good question that I get a lot of times is, do I need hip preservation surgery for a labral tear? Is a labral tear something that requires surgery? Is it something that's dangerous in the hip joint? And a lot of times patients will, maybe they went to see their primary care doctor and they were having some pain and they got an MRI of the hip and it showed a labral tear of the hip joint. Or maybe you saw your OB/GYN doctor and you got an MRI for some other reason, and that they picked up a labral tear on that MRI, and that label, and so now you're saying, okay, I've got a labral tear of my hip joint that I didn't know about. Maybe I don't even have hip pain, but you're wondering, is that a dangerous thing to have? So one thing to understand is kind of back to this idea of arthritis. First of all, when you have arthritis of the hip joint, osteoarthritis of the joint, by the nature of that condition, there will automatically be labral tears present because the bone starts to damage the labrum. And so if we were to get an MRI in that patient that I showed the picture of that had the bad arthritis, the labrum would essentially be destroyed. So the labrum would be in bad shape and have tears and things like that. So a lot of times we'll have conditions where maybe a patient has an MRI of their hip joint and it shows some arthritis, but it also shows a labral tear. And they say, well, yeah, but how do we treat the labral tear? What about the labrum? Do I need to worry about that? And the thing that patients need to understand is that the arthritis in that point is overweighs the labral tear or trumps the labral tear in terms of the treatment. So that labrum is kind of labral tear is a sequela of the arthritis in that situation. And so it's not something that you have to worry about being like, oh, I have to treat the labrum or I have to fix the labrum to prevent further damage or anything like that. The main problem in that scenario is arthritis. But say there's not arthritis in the hip joint. Say that, you know, you just have that labral tear and the rest of the hip looks good, but there's just happened to see a labral tear of the hip and maybe the hip doesn't hurt you much. The takeaway point there is that we have no indication that a labrum tear itself is going to cause further damage or further pathology in the hip joint. So the real reason to treat the labrum tear is if your symptoms are not getting better without, with the non-operative treatments and things that you're doing. So treating the labrum is all about the symptoms. The last thing that's really important is the labral tear really the problem? And I run into this with patients a lot. And this is one of the most tricky things about hip preservation that we deal with, is that if you were to draw a circle around the hip, right, and consider what's in that circle, there's a lot of different things. There's the hip joint, there's the spine, there is GYN issues, GU issues, GI things that can cause pain. So there's a lot of things right around that area that can cause significant pain that's not necessarily the hip joint, but it can kind of mimic hip problems. And so again, sometimes you pull up that MRI, it shows a labral tear. We think that maybe that could be where the pain is coming from. But sometimes we really have to search to see, okay, is the labrum the main problem or not? And in certain situations it is, and it needs to be treated to fix the symptoms, but in certain situations it's not. So the biggest pathology that I see that causes labral tears, or the most common pathology I see that causes labral tears, is impingement, or femoroacetabular impingement. And what this is where the shape of the bone, where the head and the neck is, there's a bump of bone right there. And there's a thought that this is either you're kind of born with this and genetically disposed to it, or you develop this over time during development and as you mature and as your hips mature. But in any case, that extra bone can pinch up against the other bone in the hip joint, and it can damage the cartilage, it can damage the labrum. And so it's just that pinching motion that causes it. Alternatively, you can have a little bit of extra bone on the socket side, and that bone can also pinch up against the other bone. So it can be either on the socket or the femoral side. If it's on the femoral side, we call it a cam impingement. If it's on the socket side, we call it a pincer impingement. And those can definitely cause labral tears, and they cause pain in the hip joint. Now, the next picture I'm going to show, these are from open hip surgery, okay? And it just shows what that pathology actually looks like. So if you're a little bit squeamish with things like blood or things like that, you may want to just kind of not look up at the next pictures, but it shows you what the cartilage looks like of the hip joint, and it actually shows you what that impingement looks like, okay? So if you're a little squeamish with those things, maybe you don't want to look at these next pictures. All right, so this is what it looks like. So this is the picture on the left, is where you can see that the ball, this is the hip socket, the top of the femur, the ball part. And you see that it's not round. So there's this tool here that's measuring how round the hip is. And you see that that tool can't go down because it's got a little bump of bone there. And that's that cam lesion. So you can see how that bump of bone would hit up against the other part of the cartilage and cause problems. Now, this is after this has been shaved down in an open surgery. And now you can see that it's nice and round there, and that prevents that's how you get rid of that impingement. Now, normally we don't have to do that in an open surgery. We usually can do it in another way, but this is a good example, and it shows you what that impingement looks like. This is a pincer impingement. So this is where there's a little bit of extra bone on the socket side. That structure that's being held right there is the labrum. And you can see how that labrum is just kind of peeled off there. And so in this situation like this, that bone's been shaved down, and then eventually we'll repair that labrum down to fix that labrum back down to bone to remove that impingement. So that's what that looks like. So I want to talk, we're going to talk, the rest of the talk's going to be, okay, what does hip preservation surgery look like in most cases, right? And I'm going to focus mostly on impingement and labrum tears. So most of the time, hip preservation surgery, we perform it using an arthroscope. So we use this camera that goes into the hip joint, and we use it, we make small poke incisions around the joint, and that allows us to get that camera into the joint to look at the structures inside the joint, look at the labrum, look at the cartilage, and to perform the procedure that way. So it's through usually 2 to 3 small little poke hole incisions, less than 1 centimeter incisions around the hip joint. And using that scope, we're able to repair the labrum and reshape the bone to prevent further impingement and further damage to the joint. Right. So I thought it might be helpful to just kind of go through a case presentation and what it may look like for a patient to go through this process. So this was a patient, it was a 15-year-old competitive soccer player, young woman, and she had a pain after a fall in soccer. So it was kind of an acute thing, and then she started having pain after that. The pain with her was located in the anterior groin. It was located worse with athletic activities, and she had positive anterior impingement signs. So when I asked her, okay, where does it hurt? This is generally what what she showed me. It just hurts right in between here, and we call this a C sign. This is a common thing when patients have hip impingement or labrum problems or something that may need hip preservation. This is generally where patients will feel the pain. And then on exam, this is one of the exam findings that we do. We do flex the hip up and internally rotate the hip, and that will frequently recreate the pain that you have. And if that situation, we'll call that an anterior or positive impingement sign. All right. Now, this is this patient's x-rays. And interestingly, this patient, we don't see a whole lot of impingement on this patient's x-rays here. Overall, these x-rays look fairly normal. The patient's still skeletally immature, so she's got a little bit of growing to go. And she actually has maybe a little bit of undercoverage of her hip joint, so maybe some mild borderline dysplasia. She had an MRI, and the MRI showed a little bit of a labrum tear up at that superior part of the hip there. So we saw an MRI on her exam. So in a situation like this, where we're not seeing much on the x-ray, we didn't see much on we saw that labrum tear on the MRI, and she's been having a lot of pain. Sometimes I'll get some more information and I'll get a CT scan. And with the CT scan, that's where we really found that she had a big bump right here. This is almost like a heat map right here, and it shows that big bump of bone on the femur that's causing the pain. So we decided to do surgery for this patient, all right? And this is a picture from during the surgery of when we put the camera inside of the hip joint and the type of pictures that we can get. So when you look at here where that fraying is and stuff right there, that's actually the part of the cartilage of the hip joint, where the cartilage has kind of been peeled away because that bone is hitting up against cartilage. Up above that, we can see the labrum, and where the labrum is displaced from the cartilage in the bone right there. And that's generally what it can look like. Now, this is a pretty severe situation right here. This is a pretty bad impingement because of how big that bony piece was. All right. This is where we've actually repaired that. So we pulled the cartilage kind of back up to the edge of the labrum, and we repaired that labrum back down to the cartilage as well in the bone. And we do that using little anchors that go into the bone. We can pass the suture either around or through the labrum to repair that labrum back down. Now, on the left here, this is a picture of where we've done the labrum repair. You can see the stitches up top here. And then you can see the labrum where there's nice healthy labrum right there. And the hip is still out of the socket right there. On the right side, this is as we put the hip back into the socket, and you can see how that labrum is now recreating that nice suction seal again to allow that hip to function normally. Now, this is what it looks like when we've shaved down the bone right here. So we actually removed that big piece of bone with a burr, and we can see the labrum right next to where we've shaved the bone down. And so we can see that that lesion is no longer going to impinge up against the labrum. And that's how we can confirm that we've taken the correct amount of bone. And this is where we've repaired her capsule and everything at the end of the case. Now, I frequently will use X-ray at the time of surgery to make sure that we actually got the bone resected properly. And you can see right here where this is a picture from the surgery where we had the burr right there about to shave down that bone lesion. And you can see where there's that bump of bone, that extra bump of bone right there. And this is after we've resected most of that bone. And you can see how we've taken that down and we've made it where now the hip is nice and round there and it comes down and there's no longer that large cam lesion there. These are pictures that we'll get where we get these, we can make measurements before and after, and you can see on the left side, this patient had that impingement and that bump of bone in the right side that's no longer present. So we've done a good job of shaving down that extra bone to hopefully prevent further problems for this patient. So finally, a little bit about what does recovery look like for this hip arthroscopy or hip preservation type procedure. Little bit about it. So first of all, it's an outpatient procedure. So most hip preservation surgeries we can do the same day, and you go home the same day. Usually takes about a couple of hours or so, hour and a half, couple hours to do the procedure. But you're able to go home the same day, and you don't have to stay in the hospital. Usually we'll allow you to put full weight on your hip after surgery. Now I usually give patients crutches to kind of help them get around after surgery because they may not feel like putting all the weight on the hip joint. A lot of times patients come back to me at about 2 weeks and see us in clinic. And usually at that time, a lot of patients are feeling well, off the crutches, and not having too much pain in the hip joint. Usually walking around at about 4 to 6 weeks, maybe still having a little bit of soreness, but overall able to walk around and do daily activities and things without pain in the hip joint. Straight ahead running for most patients is usually about 3 months. And then what takes a while for these procedures is to be able to get back to sports and athletic activities and things like that, because you have to get all the muscles strong again around the hip after the surgery. And so that's what can take a little bit longer, and that can take maybe 5-6 months or so. All right. So that's essentially what a hip preservation surgery looks like. Usually we use that scope to perform the procedure, and we can have very good outcomes with that in the right patient. So, so I hope that was helpful. Went through a little bit about, hopefully you understand better now about maybe who is a candidate, who's not a candidate, how you can understand if you're a candidate, and then what that procedure generally looks like and what it's, what pathology we do that procedure for. So, so I want to stop here. Appreciate your time. And I want to leave plenty of time for the question and answer, because many times that's really the most important part of this talk.
Thank you so much, Dr. Johnson. That was some great information. We do have some questions already. So our first question is, post-surgery, what are the movement restrictions? Will a patient be able to put on their socks and shoes without assistance?
Yeah, that's a great question. So it depends on the type of procedure. So if you have a hip preservation type procedure, a lot of times we'll limit a little bit of that flexion to about 90 degrees. But a lot of times patients with that restriction can reach down and be able to get their socks on. A lot of times with a hip replacement surgery, usually for the first couple of weeks or so, we may say, okay, we don't want to bend that hip up too far for that period of time. And so you may want some assistance with putting on like socks and shoes at the early post-operative period.
Great, thank you. So if someone has already been diagnosed with hip arthritis and has a popping sound there with movement, does that rule out any hip preservation surgery, especially if the patient is almost 72 years old?
Yeah, that's a great question. So I would say once a patient has hip arthritis, the utility of a hip preservation surgery is just not as helpful. And what we found with our studies and our literature and things is that when that joint space starts to narrow and the arthritis gets worse, then patients just don't get better with these hip arthroscopy procedures where we repair the labrum, shave down the bone spurs and things like that. So usually we don't offer that type of procedure when there's significant arthritis. So in that scenario, if things aren't getting better with non-operative treatments, we would recommend a hip replacement as a surgical solution.
Thank you. And how can you tell if your hips are uneven?
Sometimes it's can be a little bit hard to tell because there's different reasons for having uneven hips. It could be that the actual leg length is different from one side to the other, or it could be that there could be something going on with the spine or the musculature that will shift the pelvis up a little bit on one side or the other. But generally, if you find that if you lay down, if I have a patient that lays down on the table and I bring the legs together, I can generally measure that difference fairly well. To just give us a sense, is there some sort of discrepancy or not? Now, if we get an x-ray and we get a full length standing x-ray film, then we can actually measure those differences and tell you, okay, is there a true leg length discrepancy or if the hips are at different heights?
Thank you. And what are some exercises that seniors could do to improve their hips?
Yeah, absolutely. So a lot of times hip arthritis or even other hip conditions will cause tightness and cause the muscles to get really tight around the joint. So I find that stretching and mobility is probably the most important thing. So, and I tell patients a lot of times that going to see a physical therapist can be really, really helpful. And it's not a situation where you've got to go see the therapist and go all the time or go, multiple times a week or go for months or anything like that. But I tell patients just go see the therapist, go once or twice, have them teach you the exercises and how to stretch and things like that. And if you feel like you get a lot out of going in person, then keep going. But at the very least, ask the therapist and they'll give you those the right exercises and stretches and things to do. But I think stretching and mobility is probably the most important part. The other thing I like is I really like low impact exercises. So things where you're not putting a lot of pressure on the hip joint, things like aquatherapy where you're in the pool and you're taking the weight off of it, or like a recumbent bike where it's more about motion and less about pressure on the hip joint. So those types of activities and exercises I really like.
Thank you. And what do you recommend for osteopenia or osteoporosis?
Yeah, so osteopenia and osteoporosis are very important things to consider for the hip and for our overall health. Those conditions are oftentimes they're under recognized and undertreated, and they can put you at risk for things like hip fractures and spine fractures, and that can be very, very debilitating and a major health problem. So for osteoporosis and osteopenia, if you're have not gone through, say if you're a woman and you haven't gone through menopause yet, you can really do a lot to maintain your bone health by things like calcium, vitamin D, high impact activities in the early on, and that can help you preserve that bone health. Now, after menopause in women, a lot of times your bone, what you've built up in terms of your bone health and your bone density and things like that, a lot of times, a lot of that is already set. And so things like vitamin D and calcium are not are still important, but they can't have quite as much effect as they do before. So then it's important to really talk to your primary care doctor about getting tested, getting things like DEXA scans that can evaluate you for osteoporosis and osteopenia. And sometimes if it's significant enough, there are certain medications that can be really helpful, things like bisphosphonates or other medications, things like parathyroid hormone and pulsatile fashion that can help really increase bone density and prevent things like fractures. So that's one I really defer to the patients. I have them talk to their primary care doctor to make sure that they're having that managed. Sometimes if it's significant enough, you can actually go see an endocrine specialist or a metabolic bone clinic that can help treat those conditions.
Great, thank you. And for a patient that this person in particular is 75 years old, would you, in your opinion, do you think it is worth it to go in for a hip replacement?
Yeah, that's a really good question. There's a lot of factors that go into it. What I tell patients all the time is that they tell me when they are ready to do a hip replacement. I don't ever tell them like, look, you need to do this, because it's all about how you feel and your symptoms. There's nothing dangerous about hip arthritis. So it's not a situation where you need to worry about it getting worse or causing further damage to your body or anything like that. It's all about symptoms. So what I tell patients is that trying non-operative treatments and things can be helpful to just see if they work. There's really very little downside to doing things like physical therapy or anti-inflammatories. Sometimes injections and things like that can be helpful. But if it gets to the point where those things aren't helping and you're having pain a lot and you're thinking about it all the time and you're not able to do things you want to do, then a hip replacement can be a really, really good option and maybe something that you want to consider.
Thank you. And so if a person has a curvature of the spine, are hip problems inevitable?
Not necessarily. Yeah, it's not something that is inevitable, I would say, but everything is linked. And if you have, say, curvature of the spine, or say you've had the spine procedure where the spine was fused, or sometimes that can put extra stress on the hip joints, and that can lead to pain and things like that. But no, it's not an inevitability that a patient with spine issue or spine curvature or scoliosis is going to have hip arthritis or hip pain.
Okay, great, thank you. And what are the symptoms of arthritis? Is it more of a sharp pain, dull pain, or leg weakness?
Yeah, that's a really good question as well. I think it depends on the patient. It's not always going to be the same type pain, but I would say that there's your quintessential type pain or whatnot is usually kind of an aching pain, deep pain in the groin type area, that C sign that I kind of showed you earlier, in that area around the groin, that's worse with weight bearing, can frequently be worse, kind of stiff in the morning and then kind of loosen up a little bit, but then kind of be painful as you go throughout the day. And in the evening, if you've been a lot really active on it, then it can start to ache and things like that. So usually kind of a aching pain deep in the joint, but sometimes it can be sharp depending on the situation.
Thanks. And so, in terms of recovery, what is the difference between minor or full replacement?
Yeah, so nowadays there's really, when it comes to hips, when you're talking about replacement options, there are two options that are really kind of considered. One is called like a hip resurfacing, and the other is a full hip replacement. Hip resurfacing, that's done at some places, and some specialty centers will still do hip resurfacing. But the use of hip resurfacing is actually fairly minimal, and I don't utilize that usually in my practice. So hip replacement, like a total hip replacement, is where you're replacing both sides. That's the gold standard, and that's usually what we recommend for hip arthritis. So really comparing the two, if you did have like a hip resurfacing or whatnot, maybe that recovery could maybe be a little bit shorter, but probably not too significantly different between the two. Now, I think another thing to consider is, okay, what's the recovery on a hip preservation procedure versus a hip replacement procedure? And I think that's a really good thing to think about. A lot of times patients think that, well, the hip preservation procedure recovery is going to be a lot easier. And actually, those recoveries are fairly similar. And in fact, maybe the hip replacement recovery can maybe be a little bit shorter at times, because you're replacing the joint. You can actually put weight on that right away. You don't have to wait on like tissues to heal, or that sort of thing. So actually the hip replacement recovery sometimes can be pretty quick.
Okay. And what condition causes soreness in the back of the hips? And does physical therapy help with that?
Yeah. So that one can be a tricky area. And that's why I talked about how these things can overlap sometimes. So I would say in the back of the hip, the most common reasons to have that could be arthritis. So arthritis can present with pain kind of towards the posterior part of the hip joint. Sometimes there can be an issue with the bursa around the hip joint. So you can get a trochanteric bursitis. They can give you pain along the side and the back of the hip joint. And that can cause pain out there. Things like glute medius tears can also give you pain around that area. But then there could be things that aren't necessarily related to the hip that will also give you pain around the posterior part of the hip, especially if that pain's radiating down the leg. That's when you start thinking maybe it's a spine issue. And the spine can frequently be a culprit in posterior kind of buttock or hip pain.
Thank you. And do you know of a good online resource for hip and knee exercises?
Yeah, so there's there's some that I send patients. So I have like charts and things like with the actual pictures on them and things like that I send patients to. In terms of an online one, I don't really have a go-to like video or that sort of thing that I usually send patients to. I really truly believe in physical therapy and having therapists teach these exercises, because I think it's just so much more fruitful that way. But a lot of times if you search for specific exercises for, say, stretching the IT band and things like that, you can find really good videos online. And that may be something I need to look into, is maybe trying to find me some good go-to. What are my go-to people that I like, that I have online that I look for? So that's good. Maybe that's a good question, and maybe encourage us to have that available.
Thank you. And so if someone needs surgery on both hips, how long between the two is suggested?
Yeah, so whether it's a hip replacement or a joint preservation procedure, usually that timing, I will say with a hip preservation procedure, I usually will wait about 4 to 6 weeks, about 4 weeks minimum between sides. And I usually don't recommend doing it at the same time. With a hip replacement surgery, many times I'll recommend maybe spacing that out a little bit further. So maybe more like, 8 to 12 weeks or so minimum between the procedures.
Thank you. Okay, and with hip replacement, uneven leg length is a possibility. Is that common, or what do you do to prevent that?
Yeah, so it is a known thing that happens, that can happen with hip replacement surgery. And now usually that leg length discrepancy is within about 1 centimeter or so. And I tell patients the main thing with hip, when we're doing a hip replacement, is we want to have a good stable hip. We don't want to have a hip that dislocates, because when we do a hip replacement, it's not held in place, like it's not locked in place. It's held in place by your own tissues and your own muscles and things. So we have to rely on that tension. We have to get the correct tension. And sometimes that means by lengthening the leg a little bit from where it was before. So there's always the chance that there's going to be a little bit of a discrepancy, maybe within 1 to 2 centimeters. It's usually acceptable of a leg length discrepancy. We usually try and get those as close as we can, and we have reads during the surgery. If we're doing an anterolateral approach or a posterior approach, then usually those reads are the tissues, and we'll kind of see where the tissues come down. We can kind of check the knees and the feet at the time of surgery and just kind of see where those leg lengths are to check on them. If we're doing an anterior approach, one benefit is that you can get x-ray at the time of surgery to actually check the leg lengths and make sure that those are pretty similar, at least radiographically. So those are some of the ways that we do that.
Thank you. And what factors are considered when the patient needs hip surgery, but they also have osteoporosis or osteopenia?
It just depends on the severity of it. It's not not something that a patient with osteoporosis or osteopenia can definitely have a hip replacement surgery and do just fine with that. Now, we like to have those things treated as well, and that may be able to increase the benefit of the surgery and also decrease the risk of complications during the surgery. One thing, say we have a patient that we know has osteoporosis or osteopenia, and we know their bone's going to be softer or weaker than another patient, then at the time of the surgery, we know to be a little bit more careful when we're putting that implant down or that stem down to try and prevent like a fracture of the bone while we do that. And maybe a situation, if it's significant enough, that maybe instead of press fitting the implant in, that maybe we want to cement that implant in place to prevent that risk of fracture.
Yeah. And do you recommend Prolia for osteoporosis, or have you seen patients who have had fractures due to Prolia?
Yeah, so that's a really, really good question, and there's a lot of nuances, with that. The ones that we normally use for osteoporosis, and again, I usually kind of defer to our primary care doctors or endocrinologist or metabolic bone specialist to treat osteoporosis, but there's different types of medications. The ones that's been used most commonly is their bisphosphonates. And with bisphosphonates, we found that we like to give a break after so many years, 5 to 7 years, because we found that if you're on that medication for an extended period of time, it can lead to the risk of things like unusual fractures around the hip joint. Now, if you consider all comers, the risk and benefit of those procedures, from the amount of fractures that you're preventing by using the medication dramatically outweighs the amount of fractures that would happen due to taking the medication. And I think we're going to find that that's a similar thing for Prolia or denosumab as well. Forteo is another medication that may not have that same risk. And Forteo is that pulsatile parathyroid hormone. Very, very good medication as well. So these are all good medications that can be used in certain circumstances. And really, I think I really encourage you to talk about your primary care doctor, or if you have significant osteoporosis, talk to an endocrinologist about that.
Thank you. And we just have one final question. So if someone develops fairly sudden pain and lack of movement in the right hip, the x-ray showed moderate osteoarthritis in the spine and right hip plus scoliosis. And it was accompanied by extreme swelling in the hip area. Is that common?
I would say it's not the most common presentation for something like arthritis or that sort of thing. If it's an acute injury like that, and it's really severe and the patient's having a hard time bearing weight, that is a situation where we may want to get an MRI and just check to see if there's something else going on, like a subchondral fracture of the hip, or maybe like an osteonecrosis of the hip or something like that could be going on. And so we may potentially check a little bit further if it's a really, really significant pain and the patient's having a hard time bearing weight and it's not getting better. Now, if we see significant arthritis on the x-ray, then a lot of times that could just be the arthritis itself that's causing that problem.
Great. Well, thank you so much, Dr. Johnson. This has been great, and there's been so much valuable information shared. So I just want to thank you for taking the time out of your day to share with all of us. And again, this webinar will be sent out to everyone after for watch back. So thank you again, and I hope everyone has a great rest of their day.
All right. Thank you so much for having me. Appreciate it.